hepatitis, and I'll be talking on diagnosis and monitoring of Hep B and C infections. Now we know that large part of the world's population is affected by the silent epidemic of viral hepatitis, and both these viruses together have estimated to cause about 500 million chronic infections with 1 million deaths annually. Now in India, we have 40 million people who have chronic Hep B infection, with 6 to 12 million with chronic hepatitis C infection. Now this problem is further amplified manifold in high-risk groups, as we have seen in the previous talk, as well as in HIV co-infected individuals. Now but the good thing is that hepatitis B infection can be prevented effectively by a vaccine, while both these infections can be effectively treated. Now let's see first about hepatitis B. Now this is hepatitis B is a DNA virus, and the main antigens are the hepatitis B surface antigen, the core antigen, and the hepatitis B E antigen, which is a nucleocapsid antigen. Now let's quickly go over the course of the infections. Now what happens in acute infections? In case of acute hepatitis B infection, the first marker to appear in blood is the hepatitis B surface antigen, which appears 1 to 4 weeks after infection. Now this usually disappears after say 2 to 6 months, and its disappearance is heralded by the appearance of its corresponding antibody, that is anti-HBs, which is a protective antibody. Now hepatitis C antigen is not seen, core antigen is not seen in the circulation, but its corresponding antibody, that is anti-HBc, is seen a week after appearance of the surface antigen, and this antibody remains lifelong, and this is a marker of prior infection. For the first 6 months it is the IgM type, and later the IgG. Now simultaneously with HBsAg we have the HBe antigen appearing, which is a marker of active replication. Now what happens in case of chronic infection? In case of chronic infection, the hepatitis B surface antigen persists for more than 6 months, and along with this, concurrent presence of E antigen indicates that there is active viral replication. Now what are the tests for diagnosis and monitoring of hepatitis B infection? First of all, we have the serological tests, which form the primary diagnostic tests, which are done for to assess the presence of infection, the disease status, is it chronic or is it acute, and so the ones that are bolded ones are the primary tests that are used. Then we have molecular tests for diagnosis of chronic hepatitis B infection as well as for management. So these are the viral load assays. Then we have genotypic assays, which help to predict the course of infection and the effectiveness for treatment. And then we have antiviral resistance monitoring assays. In addition to this, very important, we have routine laboratory tests that are done for assessment of the liver status and monitoring the response to therapy. So we have the hepatic panel, out of which serum alanine transaminase is the mainstay, along with the others. Now this is a typical interpretation chart for of the serological test, which is very readily available. Now let us go on to chronic hepatitis B. Identification of this infection is very important because treatment is indicated in these cases. So now progression from acute to chronic depends on when a person acquires acute infection. So if he acquires in the perinatal phase, 90% of them are likely to proceed to chronicity. If the person has acquired it in less than 5 years, 25 to 30% will go into chronic infection, while if the infection is acquired in the adulthood, it's only 10% who will go into chronicity. Now chronic hepatitis B as classically has 4 phases, and it is not mandatory that a person passes through all these 4 phases. So here we've put up the markers along with the stages. The first is the immunotolerant phase. So if a person gets this infection in the perinatal phase, it is a replicative infection which is seen by very high HBV DNA levels, but the liver enzymes are normal. The second is the immune active or the immune clearance phase, wherein the viral load is very high. The liver enzymes are also elevated. While following this, there is an inactive phase or a phase of zero conversion, wherein the E antigen goes off and a corresponding antibody develops, and the viral load is also undetectable. Sometimes what can happen is that a person from chronic hepatitis B infection can have active replication even in the absence of HBe antigen, and this is known as the immune reactivation infection. Now these stages are very important because treatment essentially is guided by these stages. Now, okay, among the molecular tests, in addition to diagnosis and evaluation, these tests can be used to diagnose occult HBV infection, for assessment of emergence of antiviral resistance, and for assessment of response to therapy. And all the current commercial tests that are available have a very good sensitivity and analytical performance compared to the first generation tests that were earlier available. Now, antiviral therapy, there are 7 FDA approved agents, including 2 interferons, 2 nucleoside analogs, and the 3 nucleotide reverse transcriptase inhibitors. Now, depending on the stage, the patient will be initiated on therapy. Now, how is the monitoring done during therapy? Now, monitoring is done essentially to look at the side effects of the medications that will depend on the individual drugs that are chosen. And most importantly, monitoring is done to look for a response to treatment. Now, here I've just put up the general approach. So, at baseline, we look for the quantitative or the hepatitis B viral load. This is followed by the liver panel test. Then the patient is initiated on therapy. After 12 weeks, again you follow up. Now, if the patient has a more than 1 log decrease in viral load, the therapy is continued, and then at 3 or 6 monthly intervals, again the liver panel and the quantitative tests for HBV DNA are done. But if the HBV DNA decreases less than 1 log, then we have to look for 2 things: assess the adherence. If the person is properly adherent to the regimens, you have to 2 important considerations. It can either be a primary non-response or it can be a virological breakthrough. We'll just come to that in a short time. Now, what are the endpoints that we are assessing or that have been monitored? First is biochemical response. Herein, there is decrease of serum ALT levels to normal range. We have to look for virological response, wherein there is the HBV DNA goes on to undetectable stages, and there is seroconversion of hepatitis B antigen. Then we also look for histological response, wherein there is 2-point or more decrease in the histological activity compared to the pre-treatment stage. And finally, there's a complete response, wherein in addition to biochemical and virological response, we expect a serological response, that is loss of hepatitis B surface antigen. Now, monitoring after therapy. So, this is also very essential. So, usually monitoring for LFTs and HBV DNA is done 3 monthly in the first year and 6 to 12 monthly thereafter. And if there's an increase in the DNA levels of more than 2 logs, therapy is again started. Now, what is primary non-response? Now, if there's a decrease in the HBV DNA by less than 1 log after 24 weeks of therapy, this is primary non-response. Here, usually we consider switching to an agent with a higher potency or with a different resistance profile. And what is virological breakdown? Now, if there is an increase in the HBV DNA by more than 1 log above the nadir viral load, or if the DNA is more than 100 international units per ml in patients who have achieved complete viral separation. Now, this is a very important indication of viral resistance. Now, evaluation of this entity is very important, and we have genotypic resistance assays wherein we can monitor mutations in the reverse transcriptase gene. Commercial assays are available. Now, the agent commonly resistance is seen in lamivudine, while least resistance is seen in case of tenofovir. Now, in case here, therapy should be altered before biochemical breakthrough occurs, and the usual strategy is either switch to a second agent or add a different agent. So, this is about hepatitis B. Now, let's go over to hepatitis C. Now, hepatitis C is a RNA virus. Now, here diagnosis, initial screening depends on detection of antibody to hepatitis C, and it's recommended to use a 3rd generation kits that encompasses both the core and the non-structural proteins. Now, if a test is positive for anti-HCV antibody, it indicates current infection which can be acute or chronic. It can indicate a past infection or a false positive test. So this is a screening test. So to confirm this, we have to perform a nucleic acid test to detect the presence or absence of viremia. So here, in addition to this, it also helps to guide regarding the initiation of treatment. And it's also important in case of negative HCV tests in people who are immunocompromised or who are exposed to Hep C in the last 6 months. And for confirmation, usually the tests that are used have a detection level of less than 25 international units or lower should be used. Now this is a typical testing algorithm for identifying current infection. So first testing for HCV antibody is done. If it is non-reactive, there is no antibody, you can stop at that. If it's reactive, a nucleic acid test is performed. If there is the HCV RNA is negative, there's no current infection and there's nothing needed to be done except some situation. But if it is detected, it indicates current treatment and linking to care is very important. Now, treatment is recommended for all patients with chronic infections. So we have two modalities. We have interferons or the recent directly acting agents which act against NS3 and NS5A and B non-structural proteins. Now the endpoint here we are interested in looking at sustained virological response, that is absence of HCV RNA even after completion of the therapy for 12 or 24 weeks. Now, for monitoring before starting hepatitis C infection, it is initially assessment for drug-drug interactions has to be seen, while the laboratory monitoring includes the usually hepatic panel and the complete blood count. Then in addition to this, very important, we have to do the HCV RNA, a quantitative test, and then the genotype of HCV has to be determined. And now currently with the directly acting antiretroviral therapies, it will be essential to look at for the presence of resistance associated variants by sequence analysis in the respective regions. Now, during therapy, we again look at the liver tests and quantitative RNAs at weeks 4, 12, and 24 at the end of treatment and 24 weeks after treatment. Now, discontinuation of therapy in case of HCV is indicated if there's more than a 10-fold rise in ALT levels at week 4 and if HCV viral load then 1 log at the end of 4 weeks of treatment. Now, what if a patient has achieved sustained virological response? Here the follow-up is same as if the person was never infected. So thus, to conclude, a timely diagnosis, appropriate therapy and meticulous monitoring will help us in the management of these infections. Yeah, thank you.
Sorry if I've got this wrong, but I think you're saying you do resistance, RABS, testing prior to starting anyone on hepatitis C treatment. Is that what you're advising? And do you think that's a cost-effective measure? Do you think that in patients it's going to affect the outcome with most of the direct-acting antiviral drugs giving you 95% plus cure rates? Do you believe that doing RABS is not a too costly investigation?
Of course, it's a costly thing, but for certain therapies, like say Cimapravir, they usually suggested that you have to look for certain mutations, but it's well taken.
Is it going to change your treatment, though?
Yeah.
Will it change your treatment?
I will not go for that regimen.
Right.
But if it's more than 90%, it's, this is the algorithm, but it's worth, omitting that agent.
All right. And you also do a 24-week SVR. And a lot of people have stopped doing that. They're just doing 12-week SVRs. And again, in the interest of cost and not doing unnecessary investigations, do you believe there's enough evidence still to do a 24-week one?
With this new DAs, personally, I think 12 weeks should be sufficient, but monitoring beyond, if a person has cirrhosis and you suspect some further sequelae, it may be important.
Okay, thank you very much.
Hi, I have a question. Doctor, are you still advocating invasive liver biopsy for before treating your patient, or you
I'm
need
sorry,
to,
I'm not able to hear you.
are you still advocating liver biopsy to see the condition of liver of your ICV patient, or you prefer non-invasive techniques like we have two techniques?
Okay, to my knowledge, non-invasive tests will be good, but if it's, if you are not sure with a routine serum fibrosis panel, then the next alternative can be to go to liver biopsy, but not as the first line now.
Whereas us not doing liver biopsy in Manipur, we have so many FC.
Since we're talking about liver tests, can I just, last of all, look at the biochemical tests of fibrosis, the APRI score, the FIB4 score, and whether you feel that they have a place? I don't know if, I'm sure fibroscans are available over here, but whether you feel that from a laboratory aspect they have a place or not. The APRI and the FIB4 tests, do you think they have a place?
For the initial thing, I think we can go ahead with this test. But these tests are, not that specific as the liver biopsy, but as a non-invasive, the initial line with very good this DAGs, we can of course think about them.
Okay.
Sir, I have one thing to tell. We don't do routinely liver biopsy at my place. We send for fibroscan. It approximately costs around 5,000 rupees. And whatever the other things, we are not, we know now the cure is there. And resistance testing is also, we are not advocating routinely. Thank you.
So with this, we'll conclude the session. I'll request Dr. Ed Wilkins to felicitate our speakers. Request Dr. Wilkins to felicitate co-chairperson Dr. Joshi also.
Thank you, ma'am.